Hi friends, myself Dr. Anku Jain, Psychiatry Guru. We are going to discuss important topics for upcoming exam. We start with question. In this, I start with option selective mutism. Mute in selected situation. Name itself tells you the patient is mute in selected situation, just like school. Patient is very talkative at home but is mute in school, don't give answer in the school, and when we assess the patient we found the patient is having knowledge of the topic. Patient knows the language. Patient knows the language. So language barrier is not there, knowledge is there, but patient is not speaking in the school, but the same patient is speaking at home very well. Means telling the answer very well. And these symptom continues for 1 month. Then you will diagnose the patient having selective mutism. According to ICD, the name is elective mutism. Elective mutism. So now we solve question. A 5-year-old boy is brought to your office by his parents, who says that he has not been speaking at home for last several months. These parents are concerned because this has impacted the patient academic performance. If not speaking, definitely academic performance will be affected. They are perplexed by these symptoms because when the patient is at home with them, he is quite talkative. Okay, which of the following is most likely diagnosis? Answer is selective mutism, easily explained. Now, a question was asked in INICET that selective mutism patients are usually have anxiety disorder, other anxiety disorder also present, comorbid. Most common comorbid anxiety disorder is social anxiety disorder. Social anxiety disorder or social phobia. Social phobia. Okay, other option I will discuss later on. Panic attack. Panic attack, suppose I am sitting, I am a patient of panic disorder, I am sitting quite nicely and suddenly start palpitation, breathlessness, chest pain, choking sensation. Yes, I will feel that I might be having MI, I will die, I will go crazy, my doomsday has come. So whenever you find these phrases, I will die, I will go crazy, my doomsday has come, this type of anxiety will build up and will subside in 10 to 15 minutes. 10 to 15 minutes. Okay, this is called episodic anxiety. Episodic anxiety. Okay, in generalized anxiety disorder, the patient is having free floating anxiety. In panic attack, episodic anxiety. So this is I will go crazy, I will die, my doomsday has come. Yes, feeling of impending doom, sudden severe spontaneous attack of anxiety, panic attack, and if a recurrent panic attack for 1 month, then it is panic disorder. Clear? And the treatment is golden rule of psychiatry, CBT plus SSRI. CBT plus SSRI. Sometime question is asked that what is the immediate treatment? Immediate treatment, you will do benzodiazepine to relieve the symptoms. And many time these panic attack may mimic many medical conditions just like myocardial infarction. If a person is having chest pain, breathlessness, you may think of myocardial infarction. Angina, asthma, COPD. So these questions are asked, what are the DDs of differential diagnosis of panic attack? So you know the panic attack. Now, adjustment disorder. If subjective stressor is there, what does subjective stressor means? Means the reaction to that stressor will depend on the patient, subject. Suppose financial loss, you must have seen in COVID pandemic so much financial loss, different person reacted differently to the same stressor, financial loss. In the same way, relationship problem, if relationship problem is there, just like breakup, yes, you must have heard in song Dil Pe Patthar Rakh Ke Maine Breakup Kar Liya. She was singing a song. Different person percept or react differently to the subjective stressor. तो medical illness, financial problem, relationship problem, divorce, breakup, इनको हम subjective stressor कहते हैं. We say there is subjective stressor, means the reaction depend on the subject. This is not diagnostic criteria, but most of time you will find that if subjective stressor are there, diagnosis is adjustment disorder. What I said? Whenever subjective stressors are there, diagnosis is usually adjustment disorder. Usually, for your question purpose, this is not diagnostic criteria, but yes, it will help you to solve questions. Let me give you an example. A 29-year-old lady was divorced by her husband. After that, she remained sad. Sadness. One criteria of depression is sadness, unable to sleep. Second point, don't take food, decrease appetite. Three symptoms are there. These are not sufficient to make the diagnosis of depression. Yes, you all know ICD-10. If you want to make the diagnosis of depression, mild depression 2 plus 2, two major criteria, two minor criteria. According to DSM-5, if you want to diagnose the depression, there should be 5 symptoms. 5 symptoms. Okay, so these 5 symptoms are not there, not fulfilling the criteria of depression, not fulfilling the criteria of depression according to ICD-10 or DSM-5, and the stressor is there, and that is subjective stressor. So answer is adjustment disorder. Answer is adjustment disorder. Point it out. Frequently asked question. Now, in the same question, if I add 2 more points or 1 more point, let me add 2 according to DSM-5. If I add the patient is having decreased interest, decreased concentration. Now, diagnostic criteria of depression fulfilled: sadness of mood, unable to sleep, don't take food, appetite, interest, concentration. 5 symptoms for 14 days, although they have not given the duration. Okay, if they don't have given the duration, then it becomes little bit simple for you. Okay, means you will remove the concern about the duration. Okay, 5 symptoms for 14 days. Diagnosis is depression. Diagnosis is depression. So in the same question, if they add these 2 points, the diagnosis would become depression. Clear? So remember this point. Many times questions are asked and we see subjective stressor, without second thought we mark the answer adjustment disorder. No. If diagnostic criteria of depression is fulfilled, the diagnosis is depression. If diagnostic criteria of depression is not fulfilled, then adjustment disorder. So adjustment disorder is diagnosis of exclusion. Means if you can't fit the diagnosis in any other disorder, then you will make the diagnosis of adjustment disorder. Got the point? Stage of death and dying. Human means if a person is diagnosed having terminal illness, cancer, and you disclose the news to this patient, then he will go through a phase, multiple phases. Yes, Elizabeth Kubler-Ross gave this stage of death and dying, recently asked topic, so become potential. Elizabeth Kubler-Ross said that if you disclose a person having cancer, first of all he will go in denial. No, how can I have cancer? I can't have cancer. I have never smoked, I have never taken alcohol, how can I have cancer? Deny. Then anger towards God. Hey God, why me? Then bargaining. Hey God, just save this time, I will never take alcohol, I मालती को अपनी बहन समझूंगा. Like that. Different means 125 रुपये का प्रसाद चढ़ाऊंगा, means I will do that, I will do that, this, if you this time save me. Bargaining. But after some time doctor came with the report and so told, okay, you are you can't live more than 3 months, then you will go in depression. Okay, after some time you will accept, okay, I have left with 2 months only, so whatever desire I want to fulfill, I can fulfill only in these 2 months because it's terminal illness. So this is the phase DABDA, DABDA. This is a mnemonic, DABDA. Okay, denial, anger, bargaining, depression, acceptance. Recently asked question, anger. This is not agitation. This is anger. Okay, this question was asked. And so we want that a patient who is diagnosed with cancer, we should disclose that news in such a way the patient directly go to acceptance. So this time can be saved. So there is a specific pattern to break bad news that is called Spike's pattern. That is called Spike's pattern. What is Spike? Setting, perception, invitation, knowledge, empathy, summary. This question has been asked on Spike's pattern. Okay. Now, frequently asked question and a potential question topic, somatoform disorder or somatic symptom and related disorder. Yes, somatoform according to ICD, somatic symptom and related disorder according to DSM-5. Why I am so much concerned about DSM-5 ICD? Because ICD-11 has given the name bodily distress disorder, DSM-5 has given name somatic symptom disorder, and ICD-10 the name is somatization disorder. So same disorder means same question, they may give different option and may confuse you. So now, if a patient comes to you having multiple somatic symptoms, yes, I'm having pain in chest, I am pain in back, headache is there, tingling sensation is there, numbness is there, yes, diarrhea is there, vomiting is there, means multiple systems are involved and multiple symptoms are there, you will examine. Being a doctor, definitely you will try to elicit sign. Patient present with symptoms and you elicit sign. You tried to elicit sign but you found no sign. Means symptoms are there but no signs. Yes, now you will definitely do some investigation to confirm the diagnosis depending on the symptoms. You ask multiple investigation but all investigations were normal. Yes, so multiple symptom in question, in clinical question you will find multiple symptoms, no sign, all investigation normal. Then you will say, yes, dear patient, you don't have any pathology. I think you are normal. The patient would say, Doctor Saab, tumse na ho paega. You can't do that. So he would go to next doctor. Yes, the same phenomena will occur, same incidents will occur, multiple investigation, multiple, yes, symptoms, all investigation normal. So he would visit multiple doctors. So multiple doctor. So how questions are asked? Multiple investigation, multiple doctor, all investigation are normal, no sign. Yes, what is the diagnosis? If patient is concerned with the symptoms, if patient is concerned with the symptoms, the diagnosis would be somatic symptom disorder, new name bodily distress disorder, ICD-10 somatization disorder. Clear? And in this patient is concerned with symptoms. Hypochondriasis, ICD-10 and 11 both the same name, DSM-5. Yes, in this patient would come to you, will say that minimal or no symptom are considered as sign of deadly disease, Why I made this? Yes, I am describing like this. Yes, means patient would come to you, would say, Doctor Saab, I had yellowish discoloration of urine. Yellowish discoloration of urine occur in jaundice. Jaundice is due to the liver dysfunction. Liver dysfunction may be liver cancer. Please do investigation and confirm the diagnosis of liver cancer. Means in this The patient was concerned with the symptoms. In this, patient is concerned with the diagnosis of liver cancer, like liver cancer. But the diagnosis should be lethal. Diagnosis should be lethal, deadly disease, lethal disease, HIV, cancer, corona, MI. These are hypochondriasis or illness anxiety disorder, as patient is concerned with the diagnosis. So he will visit multiple doctor, multiple investigation. So multiple investigation may be present in this and also this. But how you will differentiate? You will differentiate by, yes, if concerned with symptom, then somatic symptom disorder. If concerned with deadly disease, then hypochondriasis. Got the point? This delusion of misidentification, many times questions are asked on Capgras. You will remember by simple example. I usually say remember by the example. Suppose there is a lady which is present in ward, and she says that her husband who is staying with her is not her husband. A lady, yes, real case, there was a lady who was admitted with schizophrenia diagnosis and used to say that the husband who is living with me is not my husband. He's somebody else. He's looking just like my husband. He's behaving just like my husband. He's talking just like my husband. He's smiling just like my husband. Everything is just like my husband, but he is not my husband. When you ask why he is not your husband, she said he is wearing cap. He is wearing cap. Okay, just to put humor and just to put mnemonic, I said that he is wearing cap. Big cap grass means patient believes, that lady believes that a familiar person, her husband, has been replaced by similar looking stranger. Means my husband has been replaced by this person who is looking just like my husband, behaving just like my husband, talking just like my husband, but he is not my husband. Capgras syndrome. Clear? So you will remember the example and solve question. Free-Goli syndrome. Free-Goli syndrome, a patient says, Dr. Saab, you know that the beggar sitting outside my flat is not beggar. He is my boss. He is my senior, who has taken the physical appearance of a beggar. Yes, he is my boss. He want to keep eye on me. Yes, so he changed his physical appearance just like beggar. And you know, Dr. Saab, yesterday I went to post office. He changed his physical appearance just like a postman. Yesterday I was at road traffic, yes, red light. He changed his physical appearance just like a policeman, traffic police. He can change multiple physical appearance, Dr. Saab, but I know I can easily recognize he is my boss who changes his physical appearance again and again. Now, so Free-Goli patient believes that a familiar person, that my boss, is changing his physical appearance just like beggar, just like policeman, just like postman, and can take multiple different appearance. Can take multiple different appearance just like he is changing mask. Just like he is changing mask. So picture MCQ, Free-Goli, similar looking. When you will solve question, you may get confused between these two by definition, but if you remember the example, it would be simpler to find the answer. Okay, now schizophrenia, frequently asked question. Schizophrenia, ICD 10, 11, okay, DSM 5. In DSM 5 it is quite common, questions are being asked. Yes, these are 5 group of symptoms: delusions, hallucinations. They are called positive symptoms. They are called positive symptoms. These positive symptoms are due to increased dopamine at mesolimbic pathway. Mesolimbic pathway. हाउ टू रिमेंबर? लिम्बिक मतलब लंबा, मतलब बड़ा, डोपामीन बढ़ गया, यस, पॉजिटिव हो गया ज़्यादा, ठीक, negative symptoms are due to decreased dopamine at mesocortical pathway. Mesocortical, yeah, how to remember? Cortical, C4 come. Yes, decreased dopamine. ठीक, तो negative symptom, positive symptom, formal thought disorders, catatonic behavior, yes, catatonia. So these symptoms, group of symptoms are there. Yes, we found that out of these five, if two or more than two are present for more than 6 months. According to DSM-5, I am taking DSM-5, more than 6 months, then it is schizophrenia. If these symptoms are present 1 month to 6 months, then it is schizophreniform disorder. Schizophreniform disorder. If less than 1 month, then it is brief psychotic disorder. Okay, brief psychotic disorder or acute psychosis. In ICD, the name of the same disorder is ATPD. Acute and transient psychotic disorder. Although there is difference, but you may remember these three names are quite similar, means similar question would be asked, and many times you will find the answer brief psychotic disorder, sometimes you will find the answer acute psychosis, sometimes you will find the answer ATPD. In ATPD usually stressor is there, just like fever is also considered as stressor. Okay, now we found that, so many times you will find the symptoms and duration, you will see the duration. Yes, 6 month, 1 to 6 month, less than 1 month. Okay, ICD-10 had subtype. ICD-11 subtypes are removed, DSM-5 subtypes are removed, but even now questions are being asked. Positive symptoms, if mainly positive symptoms are present, then diagnosis is paranoid schizophrenia. What is paranoid schizophrenia? Yes, delusion, hallucination. So I make like this. If a patient comes to you, clinical question is asked, and you find suspiciousness in the question, that a patient is 40-year-old male, is suspicious over his wife, that my wife is cheating on me, means he has suspiciousness. Okay, suspiciousness is there. Now you will look if suspiciousness is at delusional level. Means what is delusional level? Means false, firm, unshakable belief contrary to evidence, not supported by socio-cultural norm. Yes, means he has false, firm belief that my wife is cheating on me. Then only and only delusion is there. No hallucination. What I say, no hallucination. Then diagnosis would be persistent delusional disorder. Yes, if means same question, if delusion plus hallucination, the answer would be schizophrenia. Yes, duration I am not mentioning here, but you all know duration of yes, schizophrenia 6 months according to DSM-5, 1 month according to ICD-10. 1 month according to ICD-10. Okay, now schizophrenia. Now in this question, if patient is having suspiciousness What I said, patient is having suspiciousness but not delusion. Many times you will find that a young person means a personality development occur in adolescence. Question is asked, and a 20-year-old, 25-year-old in question they are given, and the patient is suspicious over friendly act. What I said, suspiciousness over friendly act. Yes, 20-year, 25-year, early age. I mean, and symptoms are since adolescence. Symptoms are since adolescence. Keep grudges. Keep grudges. In question, you find suspiciousness over friendly act, keep grudges since adolescence, not delusion. Then the answer would be paranoid personality disorder. Paranoid personality disorder. Remember this point. If I say the same question 40 years and these symptoms are for 2 years, it can't be personality disorder. Suppose a 40-year-old male came to you having suspiciousness and these symptoms are for 2 years, then you can't make paranoid because personality symptoms start in adolescence. Remember this point. So paranoid personality, delusion, hallucination, schizophrenia, only delusion, paranoid, persistent delusional disorder. Now, in persistent delusional disorder, you will find occasional hallucination may be present. May be present. Remember this point. Means if question is delusion plus occasional hallucination, then answer would be persistent delusional disorder. But if question is delusion plus hallucination, no occasional word, the diagnosis would be schizophrenia. So this is question means a little bit change in the language, a single word changes the answer. If occasional hallucination, then PDD. If persistent hallucination, they don't mention the word occasional, then it is schizophrenia, paranoid schizophrenia. Which type? Paranoid schizophrenia. Okay, and we found that negative symptom, if only and only negative symptoms are present, a question is asked. According to ICD-10 clinical question, you will find that negative symptoms are present for 1 year. Then you will make diagnosis of simple schizophrenia. Simple schizophrenia has worst prognosis. Worst prognosis. Okay, while catatonic schizophrenia, catatonic symptoms are there: echolalia, echopraxia, mutism, yes, stereotypic behavior, mannerism, posturing. These are symptoms of catatonia, and if these symptoms are present, then it is catatonic schizophrenia. Catatonic schizophrenia, best prognosis. Question is asked. Catatonic schizophrenia, best prognosis, and in catatonic schizophrenia, the treatment, initial treatment, both questions are there. They ask initial treatment in catatonia. Why I saying catatonia and catatonic schizophrenia? According to ICD-11 and DSM-5. Now, catatonia is a separate diagnosis. It can be present in any other psychiatric disorder. It may be present in depression, it may be present in mania, means affective disorder, and in fact most common cause of catatonia is affective disorder. Or question is asked, catatonia is most commonly associated with affective disorder rather than schizophrenia. Question is asked. So catatonia is a separate diagnosis, but according to ICD-10, previously catatonic schizophrenia was diagnosed as if a patient is having catatonic symptom and it was having best prognosis, and the initial treatment was in yes injection lorazepam. But what is the treatment of choice? That is electroconvulsive therapy, modified ECT. Modified ECT, you all know ECT according to Mental Health Care Act, you can't give direct ECT. What is direct ECT? If you take two electricity wire and put here and the straightening of hair seen in many movies, that is not like that. But you can remember that if you are not making the patient unconscious, you are not giving general anesthesia, you are not giving muscle relaxant, and you put electricity or give electricity, that is direct ECT. In direct ECT, the disadvantage was yes, very brisk muscle contraction, there may be fracture. That's the reason that direct ECT is completely banned according to Mental Health Care Act. Yes, you can give modified ECT, and this is a treatment of choice, best treatment for catatonia. Okay, clear? Now, as I told you, best prognosis, poor prognosis. Now, recent update in according to synopsis, that previously we used to say that the developing countries are having better prognosis. Previously we used to say India was having better prognosis of schizophrenia, but now we say in developed country schizophrenia, developed country is having better prognosis, given in synopsis latest edition. Okay, so this is given in table. This is a potential question, frequently asked question, that with developing country or developed country, which one is having better prognosis? So previously we used to say developing country. Previously we used to say due to the emotional warmth, joint family, our developing country were having better prognosis. But recent finding that developed countries are having better prognosis. Got the point? Potential question. Yes. Now we come to post-traumatic stress disorder, PTSD. Suppose there is a person who bought a new car, took all family in the car and go to temple. He came out of the car, there is bomb blast. All family member died in this bomb blast. After this bomb blast, patient started having intrusion symptoms. What are the intrusion symptoms? Intrusion symptoms means flashback. Flashback means patient is sitting, the same scene of bomb blast coming inside his brain. Yes, so flashback is pseudo hallucination question. Pseudo hallucination. Inside the brain, the same image came, that is flashback. Now patient is unable to sleep. Whenever he sleeps, he has nightmares. Nightmares. So flashback, pseudo hallucination, nightmares, these are intrusion symptoms. Arousal symptoms, patient is unable to sleep, he remain hyperactive, irritable, arousal symptom. Avoidance, patient started avoiding that situation. He never drive car, he never go to temple, he avoid those situations which occurred during the bomb blast. So avoidance. If these symptoms are present after the traumatic event, significant traumatic event, objective stressor, yes, subjective stressor, was divorce, financial loss, these are objective stressor. War, earthquake, flood, rape, serious accident, no one would be saying that it's okay if they would say very bad thing happened. So this is objective stressor, and if after objective stressor these symptoms are there and patient came to you and these symptoms are present less than 1 month, the diagnosis is acute stress disorder. If these symptoms are more than 1 month, the diagnosis is PTSD, post-traumatic stress disorder, if duration of symptoms more than 1 month. OCRD recently asked topic, obsessive compulsive and related disorder. In this, mnemonic is Hobet, Hobet. Spell, I have changed the spelling. So H for hoarding disorder, O for OCD, B for body dysmorphic disorder, E for excoriation trichotillomania. Yes, you must know at least the name. You know OCD, obsessive compulsive disorder, recurrent and intrusive thoughts come in mind again and again. There is a controversy about obsession. There is a country about obsession. Yes, many students ask the same doubt, controversy again and again. According to Fish psychopathology, it is disorder of possession of thought. Possession of thought. And according to Kaplan synopsis, it is yes, disorder of content of thought. So this is controversy for a long time, and if I believe that if question is asked, go with Fish psychopathology, that is disorder of possession of thought. This is the better answer as being followed by Apex Institutes. Okay, so this is controversial, I again say, but according to me, yes, obsession should be yes classified as disorder of possession of thought. And OCD, thoughts are coming again and again in mind. Patient want to stop but can't control. If a patient can't control, means the control or possession of the patient over thought has been lost. Disorder of possession of thought. Yes, in OCD, thoughts are coming again and again. Recently asked question in OCD, the most common comorbidity is depression. Yes, sometimes the patient would have sexual thoughts towards family member, towards God, ultimately goes into depression. Yes, how can it be possible? I am not like that. Goes to depression. The most common comorbidity of OCD is depression. Okay, this question is recently asked. Okay, so wherever you find again and again thing, you will think of this is a part of OCRD. Yes, trichotillomania. Trichotillomania, a patient is pulling hair again and again, again and again. Again and again means OCRD. Yes, trichotillomania. Excoriation disorder. Excoriation disorder, a person is scratching his skin again and again, again and again means OCRD. OCRD. So excoriation and trichotillomania, according to ICD-11, these two disorders are grouped together in body-focused repetitive behavior disorder. Yes, in trichotillomania, body is the focus. Hair is the part of body is the focus. Body-focused repetitive behavior. Yes, excoriation disorder. Yes, you are excoriating. Yes, means body is the focus, skin is the focus, repetitive behavior. So excoriation and trichotillomania are body focus repetitive behavior disorder, that is ICD-11. Previously in ICD-10, trichotillomania was impulse control disorder. Impulse control disorder. But now it has been shifted to OCRD according to ICD-11, is a part of obsessive compulsive and related disorder, and in this the treatment is habit reversal therapy. Habit reversal therapy we give. Okay, body dysmorphic disorder. Yes, patient is concerned with the size of the body part. Personal ugliness is a typical example. A housewife है, psychiatry patient OPD आई, psychiatry OPD came to a psychiatry OPD complaining that her nose was longer than usual. She felt that her husband did not like her because of the deformity. Further, she complained that people made fun of her. It was not possible to convince her that there was no deformity. Means patient is not able to be convinced, means it is false, firm, unshakable belief. What I said? A false, firm, unshakable belief contrary to evidence not supported by socio-cultural norm means delusion operated by plastic surgeon. So firm that she was operated by plastic surgeon. So This is a delusional level. So her symptoms include body dysmorphic delusion according to previous concept. Yes, previously we used to say it answer should be body dysmorphic delusion, but according to DSM-5 we say even if the belief is at the level of delusion, better to mark answer body dysmorphic disorder. So in this question answer is body dysmorphic disorder. To be more specific, delusional type. Which type? Delusional type. Body dysmorphic disorder, delusional type. Clear? Now, yes, but sometimes old question you may find this option is not given, then you will mark answer body dysmorphic delusion. Another name of body dysmorphic delusion is delusional dysmorphophobia. Delusional dysmorphophobia. Dysmorphophobia. Okay, delusional dysmorphophobia. Sometimes you may find the same question. Okay, and if this is not given, then you will prefer to mark this. But if both of them are given, then answer is B. Now, OCD I have little bit idea. You have olfactory reference syndrome. Yes, delusional halitosis. Previously called delusional halitosis. Now ICD-11. They have given the name olfactory reference syndrome. Patient believe that my body has bad smell, my breath is having bad smell, so that is olfactory. Hoarding disorder. Hoarding means to accumulate invaluable item. What I said? Invaluable item. The item should be invaluable. If your mother is hoarding or accumulating the ornaments, that is not hoarding. Yes, if I keep this empty water bottle, yes, every time I drink and I save it in for future, if in future I require this, this is the reason I am so preoccupied with the thoughts come again and again. If I discard it, then it may be useful in the future. That's why I don't discard. That is hoarding disorder. Previously hoarding disorder was part of OCD. But now OCD, it has been removed from OCD. Why? Because one reason is that hoarding disorder is is not responding to ERP, exposure and response prevention. Okay, there is a controversy that OCD the best treatment is CBT or ERP. If CBT or ERP want to choose, better to go with ERP. Okay, so two controversies I have pointed out. One, OCD the treatment, yes, ERP. One is a disorder of possession of thought. Clear? So according to me, you may go with this and you will find the correct answer. So these are hoarding disorder, habit. Now BPAD recently asked question. Yes, manic episode, manic person dig fast, you know the symptoms. Mood disorder, the patient is excessively happy, sometime irritable. If happy mania, irritable mania. Psychomotor agitation, distractibilities would be there. Increased self-esteem, over grandiosity, flight of idea, over familiarity, overactivity, over sexuality, decreased need of sleep, over talkativeness. Yes, flight of idea may be there. Yes, flight of idea I have included. Yes, so a patient is having these symptoms, and if these symptoms are present, plus socio-occupational dysfunction, then diagnosis is mania. Remember this point. Yes, these symptoms plus occupational dysfunction, diagnosis is mania. If socio-occupational dysfunction absent or minimal, then hypomania. Why I am telling you, usually we remember mania 7 days, hypomania 4 days, but I keep it secondary. I keep it secondary. Why? Because if symptoms are so severe and patient can't do properly socially or occupationally, so diagnosis would be mania, not hypomania. Duration is not important criteria in that case. First point, in any question these symptoms are there and patient is hospitalized, without second thought, answer is mania. Without second thought, answer is mania. In the same question, if these symptoms are there and psychotic symptom, what I said, delusion is there. Yes, grandiosity may be idea of grandiosity, it may be delusion of grandiosity. If delusion is there, answer would be mania. So these are three important difference between mania and hypomania. Recently asked difficult question, they gave pseudo hallucination. According to ICD 10 and 11, pseudo hallucination are commonly seen in mania. Although this is not diagnostic criteria, but commonly seen in mania. So if pseudo hallucination is there, the answer would be mania. If yes, pseudo hallucination, hypomania usually absent. Fifth point, 7 days, 4 days. Hypomania, 4 days. Okay. Sixth point, flight of idea, prolixity. So I divided, yes, in this pattern, yes, these three are very important point. In any question, if you find hospitalization due to these symptoms, no need to think twice, answer would be mania. Clear? Got the point? Now, from here onwards, you will remember wherever you find the word mania, you will say this is BPAD 1. ICD 11, ICD 10, there was no classification of BPAD, but ICD 11 has classified BPAD 1 and BPAD 2 potential question. So, BPAD 1 mania, wherever you find mania, BPAD 1. BPAD 2, if mania is absent. Yes, usually we remember mnemonic like this, at 2 looks like H, I can make mnemonic very easily. 2, I can make 2 as H, hypomania. Hypomania. But it give wrong information. Sometimes you may commit mistake. That's why I avoid this. I say 1 means mania. Why I am saying like this? Look at the screen and tell me, yes, if this is mania, hypomania, sorry, depression, mania. This is BPAD 1 or 2? This is BPAD 1. If this is mania, hypomania, sorry, mania, depression, hypomania, yes, this is BPAD 1. Means if mania and hypomania both are there, mania and hypomania both are there, then answer would be BPAD 1. Got the point? So number doesn't matter. What I said, number is not the determining factor for BPAD or 1 or 2. The type is determining factor. What is BPAD 2? Suppose a patient comes to you, depression, hypomania, depression, hypomania. This is BPAD 2. Means depression is there, hypomania is there, but no mania. In the same question, if mania is there, then it would not remain BPAD 2, it will become BPAD 1, because if mania is there, BPAD 1. Got the point? Now, in a controversial question, best treatment of acute mania. If yes answer is given, one drug to choose, that is antipsychotic, lithium. This is very controversial. Many times questions are asked and we are confused between atypical antipsychotic and lithium. According to Synopsis latest edition, they have given the first line treatment of acute mania and the first drug is lithium. So according to Synopsis, you may say that the best treatment should be lithium, but Maudsley guidelines, recent guidelines gave that atypical antipsychotic, yes, are better than lithium. Okay, Cochrane review or meta-analysis has proven better result with antipsychotic, atypical antipsychotic than. So if you want to choose, better antipsychotic. Clear? Lithium, few questions are asked. If you give lithium today, that after how many days you will check the serum lithium level? After 5 days. After how many days? 5 days you will check the level of lithium. And when you will take the sample, suppose today I started lithium to the patient, we will ask patient, yes, usually we give lithium 300 TDS, 300 morning, 300 evening, 300 night. Then we ask patient that okay, you will give the sample before the dose of morning dose, means last dose he took in the night, suppose 8 p.m. In the morning the next dose will be 8 a.m. So 12 hour after last dose, means patient would give sample in the morning and last dose was at in the night. So lithium level is monitored after 12 hours of last dose question, and after how many days of starting lithium? 5 days. Clear? Now, opioid, heroin. Yes, most commonly abused opioid. Heroin is white in color. तो पता ही है heroin कितनी सुंदर white होती है, गोरी होती है ना? तो white in color, but adulteration is always there. तो adulteration is very costly. That's why it is adulterated with chalk powder, with talcum powder, with charcoal powder. No, not with charcoal. This question was asked that which compound cannot be used for the adulteration of heroin. That you know that it should not be adulterated with charcoal powder because the color is black. But even if you mix this opioid, means this heroin, with chalk powder, the color will little bit brown. Okay, brown sugar, smack brown sugar. What are the withdrawal symptom? Frequently asked question. Withdrawal symptom of opioid. Yes, flu-like symptom. You may remember in opioid withdrawal, all secretions are increased. All secretions are increased. Lacrimation, rhinorrhea, sweating. Yes, GI secretion increased, diarrhea. Okay. Yawning is quite specific. Piloreaction, yes, goosebump, mydriasis, body ache and insomnia, these are withdrawal symptom. Potential question. Alcohol withdrawal, frequently asked question and recently asked question. What is alcohol withdrawal? After 6 to 8 hours. Yes, most common is tremor. If a patient is taking alcohol for 10 years, 15 years, he don't take alcohol in the morning, means took a alcohol in the night and took a very good sleep of 6 to 8 hours. How many hours? 6 to 8 hours. In the morning he started having tremors, means most commonly tremors after how many hours? 6 to 8 hours. Other symptom, nausea, vomiting. After 12 to 24 hours he will start hearing voices, लिया लिया, अल्कोहल लिया, बहुत देर हो गई, अब तो लिया. केजरीवाल ने फ्री कर रखी है, हमारे केजरीवाल जी ने फ्री कर रखी है, वन के साथ वर्ड फ्री, अब तो लिया. अल्कोहलिक hallucinosis. Alcoholic hallucinosis. Yes, so not like that, but you will remember. Next Second day, 24 to 48 hour is second day. Yes, you can remember second day. SE for second, SE for seizure. Second day, patient may have seizure, alcohol withdrawal seizure, generalized tonic-clonic seizure. These seizures are generalized tonic-clonic seizure patient is having. Okay, these come in clusters, means in a short time multiple seizure episode would be there. And you will remember in this, never give anti-epileptic. These seizures are alcohol withdrawal seizure. Don't start anti-epileptic. Yes, if you start anti-epileptic without knowing that, without considering this alcohol withdrawal, the patient would take anti-epileptic for 3 years, 2 years. Yes, so in alcohol withdrawal seizures, you all know that we give IV diazepam. What I said, IV diazepam, according to synopsis, IV diazepam. After 48 to 72 hours, 48 means second day, 2 days, 48 means 2 days, 72 hours means 3 days, 2 means die, 72 means try. Delirium tremens. Yes, first of all, you will remember delirium. Whenever a question is asked on delirium, yes, if patient is disoriented and acute, every time they are asking question and they give a little hint. So again I am repeating how questions are asked. There is a person who is taking, yes, who is driving car or after road traffic accident. Patient got hip fracture. After that he was operated. Now he was shifted in ICU. So many history would be there. Okay, but these are not diagnostic. He was admitted in ICU. Now in ICU he is having abusive language. He is doing like this, just like catching something in the air. That is called flocculation. That is called flocculation. Picking behavior means he is doing some, just like he is cloth. He is put, yes, picking clothes. Yes, picking behavior. That is flocculation. Patient is doing this activity. Patient is having suspiciousness that these doctors want to kill me. Patient is having hallucination. Means so many symptoms are there. And they gave a word. Patient is disoriented. What I said? Patient is disoriented to time, place, person, and this is acute. As I told you, after road traffic accident, 2 days, 3 days, 4 days, acute disorientation, the answer would be delirium. What I said, acute disorientation, diagnosis would be delirium. Means you ask the patient what is my name, who I am. He say you are policeman, means he is not recognizing the person. You will say he is confused. Delirium is also called acute confusional state. Why I have mentioned this acute word? Yes, in dementia disorientation may be there, but in dementia there would be chronic course. Chronic course 6 month, you know, diagnosis के लिए how many months? 6 month symptoms. Chronic course. In delirium, course is fluctuating. Yes, in delirium, altered consciousness. In dementia, no change in consciousness level. Okay, so dementia, disorientation is there, chronic, no fluctuating course, chronic course, gradual course is there, gradual course is there. Yes, delirium, you will find fluctuating course. Yes, picking behavior may be there, hallucination, delusion may be there. Yes, in this patient also comes, yes, delirium, other name is ICU psychosis. And treatment is treat the cause of delirium, treat the cause of delirium. treat the cause of delirium. Means delirium may be due to multiple reasons, just like it may be due to electrolyte imbalance. So many reasons may be there. Whatever reason is there, treat that reason, patient would be treated. And for those symptoms of psychotic symptoms, we give low dose antipsychotic. Low dose antipsychotics. Yes. For delirium tremens, in the same question, if you find the patient is having tremors, means shaking hand, shakiness, autonomic instability, history of alcohol use, alcohol dependence, the answer would be delirium tremens. Why we are concerned with delirium and delirium tremens? To differentiate between these two. In delirium, the treatment is low dose antipsychotic. In delirium tremens, we give IV lorazepam. But in delirium, you will not give IV lorazepam. But delirium tremens, you will give IV lorazepam plus IV thiamine. Remember, in all disorder associated with alcohol, always add thiamine in the treatment, because alcohol is a very important cause of thiamine deficiency. So anywhere you find this word, yes, you will remember that alcohol related any disorder, yes, always take give thiamine as the part of treatment. And many time questions are asked that thiamine is responsible for the carbohydrate metabolism. That's why whenever we give carbohydrate in this patient before glucose dextrose, always give thiamine before dextrose. Always give thiamine before dextrose, because if you will not give thiamine, the remaining store of thiamine will be depleted and patient may present with severe neurological complications. Okay, so this is delirium tremens treatment. Now advanced directive. Yes, this question has been asked that according to Mental Health Care Act, now you can decide how you should be treated in future if you develop mental illness. What I said? Yes, suppose I am in normal mental situation, I have decision making capacity. Means I have decision making capacity means if I can know that which is harmful for me, which is not harmful for me, yes, what should be a treatment, we know the consequence of treatment, means I can decide my treatment. So I am in normal mental situation. Now I made a will, living will, just like a will. In the same way, I can make a directive, means I can direct doctor in advance that now I am in normal situation. In future, if I am unable to decide, I am not able to take decision at that time, follow these instruction. What I said, listen carefully and it will help to solve questions. Yes, in future, if I am not able to decide, then follow this advanced directive. In this I read, don't give ECT, never give ECT to me. Yes, never admit. And means I gave all the instructions to a doctor, and I said that this is my nominated representative. I made a person, my relative, my friend, that this is my nominated representative. If I have not written anything in this directive, then you can ask with nominated representative. He will decide my treatment plan. Okay. Now, patient is always better than advanced directive. Advanced directive is better than nominated representative. This is a mnemonic. What does it mean? Means suppose you made a advanced directive that I should not be given ECT, but you developed depression and you came to me and said, Dr. Saab, I am having depression, I am having suicidal ideation. As I know that this is harmful to me, please admit me. Advanced directed has given written that don't admit. Patient has decision making capacity and says that admit me. So you will follow patient because he has a capacity. I told you advanced directive is effective only when patient lose the capacity of taking decision. Now, if advanced directive has given don't admit and patient develops schizophrenia, patient is not able to take decision, so now advanced directive will work. Advanced directive will work. Means a patient is having schizophrenia, he is jumping from the roof again and again. His nominated representative came to you to say, Dr. Saab, please admit him and give ECT. But advanced directive says don't give ECT, don't admit. Then nominated representative should be followed or advanced directive. Advanced directive. Okay, because advanced directive has greater value than nominated representative. I told you advanced directive means if I have not written in this advanced directive legal paper, then ask nominated representative. Got the point? So thank you for patience listening. Best of luck. Remain positive. I usually say it's your positive thinking which help you to score more. Other than your study, your hard work, your firm determination also determine your performance. If you are positive, your performance will improve. Okay, don't evaluate. This is not the time to evaluate yourself. Yes, whatever you have worked hard, that is present either at conscious level, subconscious level or unconscious level. Many times when we assess ourselves, evaluate ourselves, we see this iceberg tip. We don't look at this portion which is going to help in our exam with great attention, good attention. So again, this is topographical theory of mind, conscious, preconscious, unconscious. Topographical theory of mind given by Sigmund Freud. Thank you.